My name is Yuz Yusof. I'm a consultant rheumatologist from Leeds, United Kingdom. I'm reporting for Room Now live from Vienna, Austria. Today is day two of Eular conference. There have been many abstracts presented. So one abstract that I would like to discuss is about the progress of CAR T cells. So in this conference, there have been so many advances pertaining to CAR T cells. And if we don't talk about CAR T cell, it probably means that you've not attended this congress. Just to summarize quickly in terms of CAR T cells, so these treatments have been thoroughly evaluated in the context of hematological malignancy, but from the perspective of autoimmune diseases, these treatments were introduced about 2 years ago by Professor George Schett's team, for which they demonstrated successful outcomes of five patients with refractory SLE who responded brilliantly and with good clinical outcomes, as well as drug-free remission. We're rolling forward 2 years now to 2024. There have been many interests by pharmaceutical companies in producing the CAR T cells. So just to recap in terms of the process, so CAR T cells stands for chimeric antigen receptor. So the principle is to induce profound B cell depletion and hopefully will then reset the aberrant immunological abnormality. So what they do is initially infuse patients with strong chemotherapies to induce profound depletion. And after that, the blood samples from the patients were taken, for which the T cells were extracted in a process called apheresis. Then these T cells would then re-engineered in the lab to produce a protein on the surface, which then respond to specific receptor. And the most common receptor will be the CD19, so that when these then re-infuse to the patients, they can attack the B cells, the pathogenic B cells. At this EULAR Congress, there is now a novel approach in terms of attacking two receptors, so not just CD19. So this is what we call it compound CAR T cells. So using a double-pronged approach of attacking two receptors. One is CD19 and one also BCMA. And the logic to attack the BCMA is because BCMA will express on the specific B cells, particularly the plasmablasts and also long-lived plasma cells. And this will result in pathogenic autoantibodies elimination. Okay, so basically, regarding to this abstract, so this was a phase 1 open label trial in China. So the presenters presented data of 12 patients, all had severe refractory lupus nephritis. All of them had a prior renal biopsy, which showed a range of classes from class 3 to class 5. And all these patients underwent the treatment, and the result was outstanding in that the majority of patients had profound clinical response in terms of reduction in proteinuria, and majority of them reached the complete renal response rate, which is proteinuria level at less than 0.5 gram a day, and the patient were drug-free remission as well. And the data were presented for follow-up just over 2 years. So people were asking as well, what happened to the infection rates? So because of the depletion of the plasmablasts and also long-lived plasma cells, people are concerned of this, but the initial short-term data showed minimal infections. So apart from mild COVID, there was one mild urinary tract infection observed. So this novel compound approach appears to be showing early efficacy and safety, and is planned to be developed in later stage of the trials. So in terms of how this is relevant to clinical practice, so in this Congress, there have been quite a few other CAR T cells data which were investigated in phase 1 open label trial. I think the key thing is about selection of patients. Because what do people mean by severe refractory lupus? How refractory is refractory? Does it depend on how many biologics that you've been undergoing, or potentially maybe when you've tried B-cell depleting therapy such as rituximab and people did not reach complete depth of depletion, so maybe these patients could be considered refractory. So yeah, so this is still in the debate. But also other important factors, including safety, because this C compound have only just over 12 months period follow-up. And even in Professor George Schatz's cohort, initially, the follow-up was up to 2 to 3 years. So we needed more longer-term data because we don't know what happened after the B-cell have returned. So potentially later down the years, then it may bring a disease relapse. And what happened then? I mean, are we going to give another CAR T cells therapy, which potential significant side effect, and etc.? So these are all questions that's still up in the air. But certainly, there has been a lot of interest in terms of CAR T cells therapies, not just in SLE, but also in other across ANA-associated autoimmune diseases. I hope you found my summary interesting, and please follow me and also Room Now on social media outlets for more coverage of Eular 2024 in Vienna. Thank you.